first slides are mainly your brush up of what you have done. But let's start with the clinical. This is what I will be covering mainly, what the NMC wants us to cover. Define and classify anemias. You must have heard of anemias. A lot of you, I hope that you're not, but some, if you're not eating well, ends up with anemia, which is mainly iron deficiency anemia. Describe the investigations, what all investigation you should tell when someone says that I'm anemic or tired. Then the etiology, investigation, and differential diagnosis of microstatic hypochromic anemia. Okay, this is what I'll be, not the macrostatic. So I'll be describing all what is microstatic hypochromic pictures, blood pictures as we go along. Okay, so this is your first clinical history. So get that when you do your exams, you will be seeing maybe a clinical history, and then what is there. This is of a 34-year-old pregnant female who had come for a routine antenatal checkup. So this female came to the gynae OPD. She gives history of fatigue and tiredness for the past 2 to 3 months. On examination, pallor was noted. So you see on the mucosal surface what the pallor is. You tell them, you see on the palpebral conjunctiva, and you feel that the patient is pale. Okay, so the cause probably out here is the increased demand. Increased demand is seen in pregnant females. You always advise the pregnant females to eat more. The recommended daily allowances for the pregnant female is more. For the infants, for the adolescents and growing adults, the recommended is always more. So the demand increase is there, and probably she is not taking her supplements. The next is of a 46-year-old lady which presented to the gynae OPD with abnormal uterine bleeding. The history here is of a increased blood loss. Okay, so the body is not able to make up for the increase in loss. In examination, marked pallor was noted. So the difference in between these two is that one is increase in demand because she is pregnant, and other is there is increase in loss. And despite she being eating iron properly or her diet properly, she is having deficiency anemia. Okay. And the next history we have is of a lady who is a known case of rheumatoid arthritis on medication. She is on routine medication, and this history of fatigue and tiredness. Anemia usually is very vague. They say I'm tired more than normal. It's usually compared, and I have breathlessness when I walk a few distance. And this lady has pallor on examination. So the common features among these three is that there is pallor, and rest of the examinations were normal. In the first two cases which we have seen, there is an increase in demand or an increased loss from the body. However, in the third case, this is of a female who is having some chronic inflammation, that is her rheumatoid arthritis. She has been having for a long duration and she is on medication. So, in the third case is because of the chronic inflammation. So, remember this, the last one is our chronic inflammation. In such cases, like in prolonged medications, like in tuberculosis and osteomyelitis, what anemia we get is anemia of chronic disease. This is what I'll be discussing today in the lecture. So before we go on to the main theory about what happens, what is happening, you should know a brief about hematopoiesis. Okay, so how is blood formed in the body is what we have in hematopoiesis. This is a Greek word, hema meaning blood and poie meaning to make. So it is a formation of cellular components in the blood and derived from the hematopoietic stem cells. Okay, so how this is all about physiology, and I have depicted this in the picture. Okay, we had stem cells in lecture on stem cells in your initial GPAT lecture. So from this hematopoietic stem cell, I discuss mainly on the hemocytoblast, that is from where it forms the blood cells, because we are dealing mainly with hemat now. We have the common myeloid progenitor and the lymphoid progenitor. From the myeloid progenitor, we have the megakaryocyte. Megakaryocyte is the one which forms your thrombocytes or platelets. Okay, from this myeloid progenitor, we have the platelets and the red cells or erythrocytes. This is from there that we have. And the mast cells, they are derived from the myeloid progenitors. Along with this, we have the huge chunk of the myeloblast. This is the WBC. This forms your basophils, your neutrophils, your eosinophils, and the monocytes in the peripheral circulation. When it goes into the tissue, it forms your macrophage or your histiocytes. This is your myeloid, which forms your erythrocytes, platelets, and your WBC. Okay, among the lymphoid progenitors, we have you must have been taught about the small lymphocytes and the large lymphocytes. Large lymphocytes are your NK cells. You must have dealt extensively on this when you did immunity. Okay. So we have the small lymphocytes. If they are derived from the thymus, then we have the T lymphocytes. If they are derived from the bone marrow, we have the B lymphocytes. B lymphocytes further goes on to form your plasma cells, which release your immunoglobulins to the blood. Your IgG, IgL all come from your plasma cells. This is just a brush up of what happens. Okay. Now, the various colony forming units are needed to form this in your marrow. For the lymphocytes, we have CFUL, CFUE, and from the for the granulocytic, we have CFUGM. These are all which are the colony forming units which is needed for the formation of the blood cells. If the patients have pancytopenia, they are given, especially GM is given when the patient is on chemotherapy and the patient is having recurrent infection because of the decrease in your TLC or total leukocyte count. Okay, this picture actually depicts the hematopoiesis in the human. So first of all, in the prenatal, what happens is the yolk sac is the first site of formation of your blood. Okay, so this yolk sac, as the child is taken over by the liver at around 1 month of age, so by 2 to 3 months, the spleen has shows a bit of a hematopoiesis, but majorly is taken by the liver. Around between 4 to 5 months, the marrow is active and starts taking over. And at the birth, it is the marrow which forms the blood cells in your body. So, among the marrow, which all sites are important? The vertebra and the pelvis and the sternum. Okay, these are sites from which we can take out the marrow. Where in the pediatric age group, you must have heard of the tibial tuberosity, from where in the pediatric age group, we do the bone marrow aspiration. So pediatric age group, we can take from tibia. However, the most common site is your pelvis. So bone marrow aspiration, one of the favorite question of the examiner, is the most common site of examination of bone marrow aspiration or the bone marrow biopsy. So among the pelvis, we have the anterior superior iliac spine and the posterior superior iliac spine. Posterior superior iliac spine is the preferred site for bone marrow aspiration and biopsy because it is very easy to assess, and the patient usually does not see what the procedure is being done, so we usually do it from the posterior superior iliac spine. I myself prefer the posterior superior iliac spine, but these are the sites from which the bone marrow examination can be done. We will be discussing about bone marrow examination and aspiration later on as we go on. We have a separate lecture on the instruments also. And this is a vital question, as I said. So we should know why we are studying this, because this is the site of hematopoiesis and we have to know the marrow elements, and we can study only when we take out from there. Okay. Now coming to the we have the red cells, we have the WBCs, and we have the platelets. Okay, so the formation of red cells is erythropoiesis. Okay, the formation of platelets is megakaryopoiesis, and the formation of WBC is your myelopoiesis. So what happens in erythropoiesis? Red cells, when you see in the peripheral blood, are anucleated. We always say the anucleated cells. Okay, is your red cells, the majority of them. So, but in the marrow, when they are in the marrow, when you examine the marrow, this is the maturation of the red cells. We have the proerythroblast, we have the basophilic normoblast, polychromatophilic normoblast, and the hemoglobinization occurs. They have the same color that of an RBCs. So before the RBCs are released into peripheral circulation, the nucleus becomes pycnotic and then extruded. And so when it comes to the peripheral circulation, the first and foremost that forms is your reticulocyte. The reticulocyte remain in circulation for a day, and then you have the red cells, which is the anucleated cells. The red cells stays in the peripheral circulation for 120 days. This is the formation of your red cells. This is the preparation of your reticulocyte stain. You can see the bluish stains out there. This is one of the supravital stain. Brilliant crystal blue, hemoglobin blue is done. You stain it and then you will see it there and then. This is your reticulocyte preparation. Okay, that was all about your red cells. Now coming into granulopoiesis, that is formation of your WBC. Okay, now myeloblasts. This is the blast. This myeloblasts and lymphoblasts, you'll be dealing more about this in WBC disorders. We have the myeloblasts, which are round to oval with high NC ratio with prominent nucleoli. Okay, so this forms the promyelocyte. Promyelocyte starts having granules in them. Okay, so the metamyelocyte, when this forms, the nucleus goes to the at one end, and the nucleus is D-shaped. That is classical of myelocyte. Metamyelocyte have a slight indentation in them. Okay, you have to appreciate the granules in them also, and band is the one which is U-shaped and more indentation compared to that of the metamyelocyte. Then if the lobulation occurs, we have the neutrophil. So that was about red cells and WBC. Among the WBCs, we have the eosinophil, we have eosinophilic granules in them, and the bispectacle shape or the headphone shape nucleus, that is the basophil lower down, which basophilic granules in them. Then to conclude with the WBCs, we have the lymphocytes, we have the small lymphocytes and the large granular lymphocytes close by, and lower down we have the plasma cell, classical of cardiac nucleus and a perinuclear of. Okay. Coming on to formation of platelets, we have the megakaryopoiesis, in which they mature, the cytoplasm breaks from the marrow and then it is released. The cytoplasm breaks and this is released as small eosinophilic granules. Then this is the platelets which we see in the peripheral blood. That was about megakaryopoiesis. Okay. So when you advise for a hemogram, this is a long list of what you have to do when you ask for a complete hemogram. So we have to do the hemoglobin, the red cell count, the white cell volume, the reticulocyte count, red cell distribution with MCV. This will be, I'll be telling you how all these are calculated. So when you do a routine blood count, these are all the investigation which is done in the pathology. This is how the reports are being made. When you see, we have how we have the red cells, WBCs, and the differential count. We have a chart. Today's lecture 2 to 4 will be telling about the automated processor and how all these charts are formed. And we do a peripheral smear study along with this. Okay, this is how you make a peripheral smear. I won't go in depth into this because a video will be shown later, which has been made by one of our PGs, and This is how you make. You should know this because this is one of your certifiable competencies, and you should make a beautiful tongue-shaped smear. Okay, this is how the smear should look like. The classical description is a tongue-shaped smear in which we have the head, the body, and the tail. Okay, so this is how your peripheral smear should look like when you're being assessed, and where you see, and you should stain it with Leishman stain. Okay, the procedure and everything will be taught to you today, and we should see the features of this between the junction of the body and tail. This is where we see the morphology of the cell, and please do the differential count on this. At the head and the body, you should never see because all the cells are just lying on top of it. Okay. How do you see a normal peripheral smear? That was the gross examination of a peripheral smear. How do you see a normal peripheral smear? Is that what is important? Okay, so this is after staining with Giemsa or Leishman stain. We have the, what you see majorly at the background, eosinophilic is your anucleate cells, are your red cells. The smaller one which I've identified here is your platelets. Along with that, we have your WBCs. We have the band forms, we have the lymphocytes, the monocytes, neutrophils, basophils, and the eosinophils. Is that what we see in a normal peripheral smear? You should know the gross, and you should know how to examine the peripheral smear, that is between the junction of the body and the tail. Coming on to the main topic of the day, that is anemias. What do you understand by anemias? Anemia is defined as a reduction in the total circulating red cell mass below the normal limit. You should know for the appropriate for the age, for the sex, because it is different for a pediatric age group, for an adult, and there is a difference between the male and the female. What happens is that it reduces the oxygen carrying capacity of the blood, thereby leading to tissue hypoxia. It is diagnosed by a decrease in hematocrit or hemoglobin concentration. So, classification of anemia, this is one of the viva question. How do you classify the anemias? Several classifications are given, but I would suggest you at least memorize one of them so that you know what is the, how do you classify anemias. Classification of anemias per se, classification is of hemolytic anemias is one of the viva questions. The underlying mechanisms can be because of increased blood loss or increased destruction. Hemolytic anemias will be dealt later on, or decreased red cell production because of deficiency or a deficiency anemia, vitamin B, or folic acid or iron. Blood loss, it can be any acute blood loss like trauma, the patient had a road traffic accident because of that, or because of chronic blood loss, just like the patient which I've said with abnormal uterine bleeding, the patient has some gastrointestinal tract, there is an ulcer, the bleeding ulcer, or it could be because of chronic infection, parasitic infection in the body. Increased red cell destruction of hemolysis, we have a separate lecture on that. It can be because of inherited genetic defects, which we have red cell membrane disorders like hereditary spherocytosis, electrocytes. It can be enzyme deficiencies, G6PD and things. So it can be membrane within this red cell, that is the enzyme deficiency or hemoglobin abnormalities, thalassemia syndrome. A lot of question comes from thalassemia syndrome, or structurally abnormal globins like sickle cell disease or hemoglobinopathies, or other unstable hemoglobin like hemoglobin N. Core genetic defects can be PNH, so you should know the classification of this. What I've highlighted is which is very important for your point of view, and it will be discussed later also. It can be immune mediated with hemolytic disease of the newborn. It can be because of transfusion reactions. You must have dealt about hemolytic disease of newborn in your immunity lecture. It can be because of mechanical trauma, cardiac hemolysis, or physical trauma. The infections of the red cell like clostridial infection. There can be because of lipid abnormality. There can be toxic or chemical injury. The patient has some toxic injury. Sequestration or hypersplenism, which will lead on to splenomegaly. Decreased red cell production can be inherited defects at the stem cells or erythroblasts. nutrition deficiencies affecting the DNA synthesis or affecting hemoglobin synthesis. DNA synthesis mainly of vitamin B12 and folic acid. This will be done in subsequent lectures. Erythropoietin deficiency, erythropoietin comes from your kidney. So renal failure or anemia or chronic disease could be because erythropoietin deficiency, immune-mediated injury of the progenitor cells, or inflammation mediated, especially your interleukin 6 mediated, which is seen in anemia of chronic disease. Sorry. Decreased red cell production because of some acute leukemias, there is some proliferative disorders, there is some space occupying lesion in the marrow which is hampering the erythropoiesis. There can be some infection in the red cells by parvovirus B19 infection. So if there is anything hampering the red cell productions or there is some space occupying lesion in the marrow which will hamper the erythropoiesis. These are the causes of your anemias. Okay. One thing which is very much important is your morphological classification, and today I'll be dealing with microcytic hypochromic anemia. Microcytic, when you see the red cells, you usually compare the size of the red cell to that of the nucleus of the small lymphocyte. If it's smaller than that, this is the nucleus of a small lymphocyte, you say it's microcytic. Hypochromia, red cells are biconjugate and usually 1/3 of a paler is there. If it's more than that, so hypochromic. So microcytic hypochromic anemias, the causes are many. I'll be dealing with this. Mainly 3. Thalassemia will be covered later when you do your hemolytic anemias. So that is one morphological classification. I'm going to revive a question, microcytic hypochromic anemia. Coming to the other spectrum is your normocytic normochromic anemia. That is the red cells. When you do a peripheral blood smear examination, they are normal size, the color is the same, but the patient is having decrease in HB or hematocrit. Because of those hemorrhagic anemias, it can be hemolytic anemias, aplastic anemias, infiltrative myeloproliferative anemias, and anemia of chronic disease. Anemia of chronic disease are usually normocytic normochromic and then goes into microcytic hypochromic anemias. Macrocytic, we have a lecture extensively on macrocytic anemias. It can be because of megaloblastic anemia, myelodysplastic syndrome, or myxedema. So as the name suggests, macrocytic, it is larger. The cells are larger. The red cells are larger in them. So we have the normal red cells, normal pallor, normocytic normochromic anemias. The cells are larger. Macrocytic anemias, that means the HB and hematocrit are less. Then the last one is microcytic hypochromic anemia. Cells are smaller, there is more hypochromia, and the HB hemoglobin are all less. That caused by iron deficiency anemia, anemia of chronic disease, your thalassemias, and your Spiroblastic anemia is microcytic hypochromic anemias. There are some indices. I'll just brush up all this because I have to go to the main topic. The MCV, that is mean corpuscular volume, mean corpuscular hemoglobin, MCHC, and red cell distribution width. So MCV, what is MCV? Is the average size of the red cells. The MCV is as hematocrit into 10 by red cells in million. It's usually 82 to 96 femtoliter. And if it's less, we have microcytic. If it's more, we have macrocytic anemias. The MCH is average weight of the hemoglobin per red cells. So MCH is hemoglobin to 10 by red cells, and it is mainly the 27 to 33 picogram. MCHC is average hemoglobin concentration per red cells. So we have normochromic MCHC or hypochromic anemias depending on that. However, we have no hypochromic red cells. So we have microcytic or macrocytic and normocytic or normochromic, hypochromic. Okay. Red cell distribution width is the index of red cell variation between the red cells, whether how much variability is there from one cell to the another. So they quantitate the amount of N-isocytosis on the peripheral blood smear. Normal ranges SD is 11.5 to 14.5%. Okay, so that was all about the parameters, indices for red cells, and what you have to know. What is the pathophysiology of anemia? Why do patients present with such symptoms if the Hb is reduced? We know Hb is the one which carries oxygen in the blood, in the whole body. So what happens is there is tissue hypoxia. Entire function of the tissues are there. The degree of impairment depends on the need of the oxygen. So the CVS, CNS, and the skeletal muscles are much more affected. Symptoms of anemia, as I said, the CVS, CNS, and skeletal muscles. In the neurological, we have dizziness, fainting, lack of concentration, headache, tinnitus, paresthesia, insomnia, irritability are very vague. Serious with angina, palpitation is what they usually come to you with. Musculoskeletal, we have easy fatigability, tiredness, and lassitude. Physical sign, the most common that we see is pallor, and especially it's noticed by your close relatives who say that you have become pale. Let's examine on the palmar crease, nail bed, and the mucous membrane. In the cardiovascular systems, because of there may be in pulse, you have tachycardia, the bounding pulse pressure is there. In the medial serious murmur, usually it can be within normal. You may not find any cardiac murmur except for tachycardia. Okay, so let's go to the main topic of the lecture today, that is your microcytic hypochromic anemia, which is caused by thalassemia, iron deficiency anemia, anemia of chronic disease, and Spiroblastic anemia. Thalassemia will be dealt later on when you do hemolytic anemias. So before we go on to iron deficiency anemia, anemia of chronic disease, and Spiroblastic, a brief review about your iron metabolism. So iron metabolism, exists in the body in the following forms as incorporated in hemoglobin or myoglobin enzymes and cytochromes is about 15% and can be stored in the form of ferritin and hemosiderin or bound to plasma. So this is about iron metabolism. This has been taken from we have the intestinal absorption, which is then from the transferrin and iron, which goes to the liver. The transferrin iron goes to the marrow erythroid precursors. Then from where the RBCs are formed, it goes to the erythrocytes. Then the mononuclear phagocytic system. Then which is then if it breaks down after 120 days, then it goes again to the plasma transferrin, then to be stored in the liver. Among some of the intestinal gut, there are some storage forms which can be lost in the gut or shed with the skin or the endometrium. This is the normal blood loss per day. Okay, so this is the iron metabolism, and this is the transport. This is taken from Robbins, which occurs inside the intestinal enterocytes. As I've said, the heme iron, which is bound in the food, non-heme iron constitute less than 5%. So the ferric form has to be converted into the ferrous form, which is done by divalent metal transporter 1. The ferric form is converted into ferrous form by duodenal cytochrome B. The heme transporter transports the heme iron as such. Okay, so after all the breakdown, what happens is that this is a mucosal ferritin which remains in the blood. However, the ferrous forms is transported by the ferroportin into the blood circulation. The ferroportin is which is transferring the ferrous by hepcidin converts it into Fe3+. The Fe3+ further combines with the plasma transferrin, which goes further to the marrow or to the liver. The liver in turn forms hepcidin. Hepcidin is a negative regulator of iron transport. That means it blocks the ferroportin, and hepcidin is increased in inflammatory state, that is anemia of chronic disease, is because of hepcidin. There is an increase in hepcidin, so the ferroportin is inhibited. So inhibition of ferroportin, what happens is that iron is not transported across to the plasma transferrin, so it is lost with the epithelial cells getting, and the mucosal ferritin is very high. This is the gist of anemia of chronic disease, but this is the normal transport across which is happening in the epithelium. Transferrin is a major transporter for iron trafficking through the plasma. It is increase in iron deficiency. So you should know that this is the one which is transferring the plasma. If the body senses that there is a decrease in the iron in the body will try to form more so that whatever iron is available is absorbed. So this is increase in iron deficiency, and in rare disease hypoparathyroidism, it is characterized by low transferrin levels, so the patient ends up with iron deficiency, severe iron deficiency anemia, and iron overloading. Hepcidin, as I've said before, is a negative regulator of iron metabolism, and it inhibits intestinal transport. So if the iron stores are low, that is an iron deficiency anemia, hepcidin expression is reduced so that the body absorbs a lot of iron. If the iron stores are high, hepcidin expression is increased so that there is no iron absorption and the iron is lost from the body. Molecular transport of hepcidin is ferroportin, which the diagram has depicted. So when the iron is lost, we do not have to go more into this. So hepcidin is decreased in hypoxia and iron deficiency. So anything which is negative regulator means the deficiency will decrease it, the increase will lead to increase that. So low transferrin saturation, low iron saturation, and increased ferritin is there because of storage hormone. So the hepcidin is increased in anemia of chronic disease, thereby inhibiting the ferroportin which is there. So you should know hepcidin in anemia of chronic disease. Okay. So ferroportin major transporter of iron, which has been depicted. I'll not go into this because we do not have much time left. Okay. When hepcidin level increases, hepcidin binds to ferroportin, induces internalization and lysosomal. This is a repetition of what was depicted and what I've explained in the picture. Coming on to iron deficiency anemia, which is one of the most common cause of anemia worldwide and in India. We should discuss more on iron deficiency anemia. You get short note on the blood picture of iron deficiency anemia, Marrow finding on iron deficiency anemia, lab investigation of iron deficiency anemia. You should know all on iron deficiency anemia. Okay, so it is the most common nutritional disorder worldwide, resulting in clinical signs and symptoms that are most related to inadequate hemoglobin synthesis. Genetic forms of iron deficiency anemias are known, which can be anything, but the most common is dietary deficiency and in developing countries, and it is amplified the intake of wrong foods or food fats, which is common now. Now it can be because of malabsorption. You must have seen in the picture how the iron is metabolized. So if there is anything disturbing in the absorption of iron, this will lead into malabsorption, thereby decreasing the iron absorption, thereby patient will end up with iron deficiency anemia. Or there is an increase in physiological demand. I have highlighted to you about a pregnant female. So if there is an increase in demand in infants, in pregnancy, lactation and adolescence, this physiological increase in demand is common even in iron deficiency or even in macrostatic anemia, vitamin B12 or folic acid deficiency. There is an increased blood loss, which I have depicted in the second case, in which the patient was having abnormal uterine bleeding, which is menorrhagia, repeated pregnancy loss. The loss can be because of GI causes, peptic ulcer, ulcerative colitis, or any parasitic infections or any malignancy. It can be urinary tract causes like hematuria or chronic dialysis. It can be others like PNH. Okay. Most common causes are dietary deficiency, deficient in diet, increased blood loss, and increased demand. Okay. So what is the pathogenesis? For pathogenic, their mechanism are, there is impaired hemoglobin synthesis. So the hemoglobin synthesis is impaired. Transferrin saturation is usually less than 15%. When the transferrin saturation, which is transferring the iron, is less, the iron which is going to the marrow is inadequate, leading to hemoglobin impaired productions, which will lead into microcytosis. Whatever iron is available will be formed in these red cells, which will lead on to small red cells with hypochromia. So it is a common cause of microcytic hypochromic anemia. So there is a generalized defect in the cellular production. The cellular production is impaired. Along with the impaired transport of the iron, the cellular production is impaired. There is degree of erythroid hyperplasia is not proportionate to the degree of anemia. The survival of the erythrocytes is also reduced in occurs in severe anemia. There is diminished iron containing proteins. You know that iron, there are some proteins which were containing iron. So it is a compound of various heme products including cytochrome, myoglobin catalase and peroxidase, which I have said. So there is decrease in such proteins. This diminution of tissue enzymes is responsible for epithelial changes in iron deficiency anemia. So these are the three stages. One of the viva questions. What are the stages of iron deficiency anemia? We have pre-latent, latent, and then iron deficiency anemia. In pre-latent, what happens is there is reduction in iron stores without reduced serum iron levels. How do you detect it? How do you know that there is detected by low serum ferritin measurement? The HB is normal, the MCV is normal absorption is increased. So body is sensing that there is a decrease in iron, so normal absorption is increased. Transferrin saturation will be normal, serum ferritin is decreased, and marrow iron will be decreased. In the latent, iron stores in the body are exhausted, but the hemoglobin levels remains normal. So HB and MCV is normal, however, TIBC is increased, total iron binding capacity is increased, ferritin is decreased, transferrin saturation is decreased, there is absent iron in the marrow. This is the, when you do a stain in the marrow, it is absent. The overt iron deficiency anemia in this, the hemoglobin and the MCV falls below the lower limits. Everything is low in this except for total iron binding capacity. These are the stages of iron deficiency: pre-latent, latent, and iron deficiency anemia. Clinical features, as I said, the epithelial changes also. The iron deficiency anemia impairs the growth in infants. So it is usually till 5 years of age, starting from 6 months, they are given hematinics. Fatigue and non-specific symptoms, epithelial changes, tissues affected, nails, the nails and tongue and mouth are affected. There can be glossitis and ankylosis. The fingers become thin, flattened, platinikia, and brittle, and finally spoon shape or polynikia. This is what I was talking about. We have angular stomatitis. We can have glossitis and platinikia or flat nails. Okay. So another syndrome which is very much asked by the examiner and favorite is the Plummer-Vinson syndrome. It is very rare, characterized by difficulty in swallowing, iron deficiency anemia, glossitis, ankylosis, inflammation around the sides of the mouth, glossitis, there is inflammation of the dorsal surface of the tongue, with deep appellation, and esophageal webs. This is very much asked in the exam. Okay. So immunity and infection, what happens in iron deficiency anemia? There is defective lymphocyte-mediated immunity, 35% reduction in both helper and suppressor T cells. So there is impaired bacterial killing by phagocytes. Pica is term which is used as craving to eat earth and striking symptoms of iron deficiency anemia. Now coming to the favorite examiner questions, or which you get as a short notice, lab diagnosis of iron deficiency anemia. Blood parameters, as I said, the patient is anemic, so the HB will be low. The red cell count we have seen that in the marrow was not forming red cells because HB was less, iron was less, so the red cell count will also be low. The hematocrit, which is the PEG cell volume, will also be low. The platelet count usually it can be normal or increased. It's usually increased if there is a blood loss in the body. Leukocyte count, it's usually normal, but mild granulocytopenia may be seen, but it's usually normal. The MCV will be low because the our red cells are microcytic, the MCH is decreased, hypochromic, and the red cell, there will be signs of anisocytosis in them. So this is the main gist of what I've talked about. The HB will be low, PEG cell volume will be low, red cell count will be low, retic count will be normal or decreased for the degree of anemia, platelet count usually or normal or increased if there is a underlying chronic blood loss. Red cell indices, it will be all low. However, RDW will be increased, that is the degree of anisocytosis will decrease. The TLC may be normal or it can be decreased. When you see a blood film, this is what the normal size red cells and normal size red color is there. This is normocytic, normochromic. However, in iron deficiency anemia, this is what happens. The red cell becomes small, there is hypochromia. So microcytic, hypochromic. In severe cases, we can see pencil cells, teardrop cells, mainly the pencil cells, it becomes elliptical in shape. There is anisocytosis, poikilocytosis. Okay, this is what will happen. Even target cells can be seen in severe cases of iron deficiency anemia. We can see platelets here, clumps of platelets, so thrombocytosis, they accompany iron deficiency anemia. Bone marrow findings. So that was all about peripheral smear finding, CBC, peripheral smear finding, then the bone marrow finding. When you do a bone marrow examination, there is erythroid hyperplasia. M is to erythroid is to myeloid is to erythroid ratio maybe 2:1 or 1:2. Micronomoblastic, this is what you call a micronomoblast, see the flaring of the cytoplasm, and they are small, and these are the myeloid progenitors. So you see micronomoblastic reaction. Myelopoiesis and megakaryopoiesis are normal. However, the bone marrow iron is grade 0 or nil. See, this is how you see improved bone pulse reaction in the iron. This actually iron is increased in this case. Okay. However, in iron deficiency anemia, you did not see any blue color. So there is 0 or nil blue color that is seen in iron deficiency anemia and is the gold standard of diagnosing iron deficiency anemia. You actually have to see 7 nanoparticles to give it as 0, so the patient will have iron deficiency anemia. Besides this, some serum biochemistries which you can do. You can see the serum iron. Normally it's 50 to 150. It will decrease in iron deficiency anemia. You can do the ferritin, which is the storage form of iron. It is sensitive for anemia and in early case signs of iron depletion. 15 microgram per or less is characteristic of iron deficiency anemia. So it recovers quickly before the iron stores are full. Coming to total iron binding capacity, it's normally 250 to 450, inversely proportional to transferrin saturation, so increase with infection. We can do the percentage of saturation or transferrin saturation, and if it's less than 60, it's specific for iron deficiency. We can also do the serum transferrin receptors, which transport iron to the cells. Receptor synthesis is greatly increased when the cells lack iron. So the serum transferrin receptors will be increased in iron deficiency anemia. Coming to anemia or chronic disease, which is one of the common cause of microcytic hypochromic anemia, and this is the case in which a patient had rheumatoid arthritis and was developing anemia or failure. So there is impaired red cell production due to chronic disease produced by systemic inflammation, the reduction in proliferative or erythroid progenitors, and impaired iron utilization. It is grouped into 3 categories: microbial infection, chronic immune disorders in which rheumatoid arthritis come, and inflammatory bowel diseases, and neoplasms such as carcinomas of the lungs and breast, and Hodgkin's lymphoma. Among the chronic microbial infections, we can have osteomyelitis, bacterial endocarditis, and lung abscess. So the classical history of anemia or chronic disease will be some of this inflammatory or neoplastic condition, and the patient will present to you with anemia. And as I highlighted before, hepcidin. Okay, interleukin 6 stimulate the increase in hepatic production of hepcidin, which is the negative regulator of iron metabolism. Erythropoietin levels are inappropriately low to the degree compared to the degree of anemia. So coming to sideroblastic, complete the list of microcytic hypochromic anemia. Sideroblastic anemias are a heterogeneous group of disorders characterized by the presence of ring sideroblasts in the marrow. There is ineffective erythropoiesis, increased level of tissue iron, and microcytic hypochromic red cells in the blood. Okay, so that is what happens in microcytic hypochromic anemia. Iron is the one, either it is deficient or there is a negative regulator of iron causing, which is of the heme. So this is what happens in protoporphyrin. In sideroblastic anemia, there is something hampering the protoporphyrin, be it vitamin B12, be it lead poisoning. And in the thalassemia, it's the globin chain which is affected. So this all leads to microcytic hypochromic anemia. Coming to sideroblastic anemia, we have the ring sideroblast, more than 5 granules covering more than 1/3 of the nucleus is what you see as a ring sideroblast, and it is characteristic of sideroblastic anemia. This is the gist of what I have been talking today, that is microcytic hypochromic anemia. In the smear, they will see microcytic hypochromic cells. In inflammation also, there will be the same. The serum iron and it's less in iron deficiency anemia. Inflammation also, it's less, between normal or high in sideroblastic and in thalassemia. Total iron binding capacity, however, it's less in anemia of chronic disease. It's normal in sideroblastic and in thalassemia. Percentage saturation of is less than 10%, and then in ferritin or a storage form of iron is less than 15. However, it is 300 to 200 in thalassemia, and the other is very high. The hemoglobin pattern, if you see hemoglobin electrophoresis of HPLC, it will be normal. However, in thalassemia, it will be abnormal. So this is the workup of the microcytic hypochromic anemia. This is taken from Dr. Singh book. So when you see a microcytic hypochromic anemia, you see the ferritin levels in the blood. If the ferritin levels are reduced, you can do a bone marrow store study. And if the bone marrow stores are nil, that is iron deficiency anemia. You give the patient hematology. However, if the ferritin assay is normal or increased, bone marrow iron is normal or increased, then you do an HB electrophoresis and you see the HbF is increased, then you can give it as thalassemia or hemolytic. If the normal HB, this should come from here, okay, normal HB electrophoresis and HbF is there, you know for sure this is anemia of chronic disease. So the ferritin normal or increase and normal HbF and electrophoresis is anemia of chronic disease. Abnormal electrophoresis or HPLC is thalassemia. So what if the bone marrow iron is normal or increased, and we see ring sideroblasts in the marrow when you do the pulse stain is because of sideroblastic anemia. That is the gist of microcytic hypochromic anemia or microcytic hypochromic red cells, smaller, more hypochromic cells. This is what happens in microcytic hypochromic red cells. And what are the causes and what study will you do to know the cause of microcytic hypochromic anemia? So the treatment will be the cause, as I've said, if the patient is with iron deficiency anemia, you take a history. I have told detail what are the causes of iron deficiency anemia. You give them hematinics. If it's because of the cause is the GI tract, you see the cause that you treat the peptic ulcer, you treat the hemorrhoids cause, abnormal uterine bleeding, you treat the cause, and the patient will not have, will be relieved of that. Okay, this is a treatment for which the anemia of chronic disease, here also you treat the underlying cause, the patient, treat the cancer, treat the rheumatoid arthritis, treat the osteomyelitis, treat TB properly, and in some cases in cancer you give them erythropoietin for it. That is all about today, iron deficiency anemia. And what I would like to tell you is that what is important from your exam point of view is your blood picture, how to interpret, how to make a smear, how to identify hemolytic anemias, and please know how to, we'll be making you do all this practical exercise, especially peripheral smear making. Exam questions, you will have your what is the lab diagnosis of iron deficiency anemia, the blood picture, the marrow findings, the serum biochemistries, and if you see a microstatic hypochromic blood picture, what is your differential diagnosis? Iron deficiency anemia should be the top, as I said.